You've tuned into Out of the Voice Box, where candid conversations bring great minds together from across the nation.
Join us for access to cutting-edge voice-related information you won't find in a textbook. Yet.
We are your hosts, Sarah Charney
and Nathaniel Sundholm.
The opinions and viewpoints on this program are those of the featured individuals, not their respective institutions. This program is not a substitution for medical care. Julie Barkmeier-Kraemer is a professor in the Division of Otolaryngology and clinic director for the University of Utah's Voice Disordered Center. Today, she is graciously taking the time out of her busy day and away from her lovely family to speak with us about the clinical utility of incorporating laryngeal function studies into clinical voice assessments. Welcome to the show, Dr. Barkmeier-Kraemer.
Well, thank you for having me. It's really a pleasure. I'm really looking forward to our conversation.
So am I. As a speech-language pathologist, your name is a name that I have heard in pretty much every voice-related class that I have taken, every voice-related journal discussion that I have been in. And so being seated across this virtual table from you is nothing but a pleasure. So we appreciate you very much.
Oh, thank you. I guess I am old enough to have been heard of now.
We love seasoned. We like to call it seasoned.
Okay, I'm well seasoned for sure.
Let's get down to business. Give us the elevator explanation. What is the purpose of a laryngeal function study?
The laryngeal function study is the use of instrumentation for achieving a fairly standard recording of the voice and measures and recordings of airstream patterns when we produce our voice, so that we can measure and quantify those patterns. And the reason you would do that is for pre to post treatment outcome measures, and as well, and probably more importantly for me, to evaluate what you're hearing with what you're measuring, to help you really understand the physiology behind the person's voice production, whether they're normal or abnormal. And as somebody who has used laryngeal function studies in my voice assessments for over 30 years now, I would say about a third of patients that I have used them on, I have gotten surprising insights about their voice physiology in contrast to what I thought I would find when I measure it.
That's so helpful to hear that level of attention to why we do these things. For the listener, if you're not aware of the purpose of a laryngeal function study, we're looking at the various components of what makes a voice. So the airflow, the vibratory signal, and the thing that comes out as a product of airflow, voice, resonance, articulation, etc.
That's a beautiful definition.
Thank you. If you want to buy it, it's for sale. No, I'm just kidding. So I have a follow-up question. And now that we know that there are different components of what makes a voice, there are some important things we pay attention to, namely acoustics, or the sound of the recording, and the airflow, the aerodynamics. There are some people who tend to value aerodynamic data more heavily. There are some people who tend to value acoustic data more heavily. Do you fall in either of these camps?
It depends on the patient. If it's somebody who has vocal fold paralysis, for example, I probably pay more attention to the aerodynamics than I do the acoustics. If I'm evaluating, for me personally, I pay a little more attention to the acoustics for somebody with vocal tremor and so forth. So I guess it just depends on the person and what the nature of their voice problem is, because both parts aren't always equally informative to me. Both parts are both important to document, though, for comparison after you treat the person, and also to keep you honest about, did you really make progress in treatment?
Absolutely. What a clear, concise answer. Listeners, If you're wondering why you take these data, just rewind 30 seconds, listen to that wisdom, reaffirm that wisdom, and keep on getting your recordings.
I love it. So when it comes to these assessments, what would you include in a bare bones, hyper efficient instrumental voice evaluation, and why would you choose to include those things?
Bare bones, I spent 5 years with a bunch of colleagues working on that for ASHA, and we published on what we came to as bare minimum. And so the bare minimum is essentially the Cape V that we came up with back in 2002, which I was also part of that monster. That is essentially all you have to do for your acoustics. We started out with a connected speech sample like a rainbow passage, but then do the Cape V, sustained vowel, ah, e, repeat some sentences, spontaneous voice. And while you're doing that behavioral assessment, just record it acoustically. You can make your measures based on the acoustic patterns you find in that exam. That's bare bones for the acoustics. For aerodynamics, it could be a variety of things. So if you don't have great instrumentation available to you, there are 2 things I would recommend to you. You can do the S to Z ratio, but really we don't have great norms on that. The maximum phonation time calculation gives you the maximum amount of time somebody can sustain phonation. And then I would do the around the house device, where you have a straw down 5 centimeters below the waterline, and you have them sustain phonation. And if they can sustain it for 5 seconds, they have an adequate amount of ability to use their respiratory system for speech, for phrasing. It's the Hickson method, published a long time ago. I bet you guys are making faces, so I bet you haven't heard of the around the house device.
Are you kidding?
1982.
I use this technique routinely, not just in evaluation, but also for therapeutic buy-in, particularly with people that have a glottic insufficiency. So the benefit of having this metered flow in a system that they can no longer control on their own is really useful. Thank you for sharing that reminder. Listeners, that is some gold. Again, rewind 30 seconds, listen to that again, process and do.
But I will add to that if you do have the equipment, we highly recommend just a sustained phonation, get the average airflow, and then the voicing efficiency, P, 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 P. And I would like to say that it's not pa, 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 and it's not buh, it's not the B sound, it's the P sound, because we want the soft palate to actually close so you get a full peak pressure in the oral cavity. Or pa, pa, pa is another, and the ah, the soft palate also doesn't always fully close. So we went with P, the P sound, as what should be used to assure with the plosive that you get a full velopharyngeal closure, and the E is a tense forward vowel, so that also maintains the integrity of that closure. So if you have somebody who has insufficiency, you don't, bias in that way. But that's it, and then you have average airflow and the average pressure that they generate. Bare bones.
What would you say is the benefit of protocol-based assessment versus dynamic assessment? And do you feel like there's a place for both?
Oh, of course. Actually, in our clinic, we have a protocol. We create a standard protocol because you need to be collecting your information for a comparable comparison between individuals, very much like we have in dysphagia, right? Yes. And we know that it's a lot more efficient if you always do the same thing with everybody. But as you're going along, you're going to notice things that make you want to do some additional dynamic or evolving assessments. Maybe you want to do some stimulability trials. Maybe you see something that's a little aberrant, caught your ear or your eye, and you want to explore that a little bit more with your patient. I think there's a place for both, and we do both things with our clinicians. So we have time mapped into our assessments for the specific routine, and then we also do dynamic assessment for any other additional things we want to explore with any given patient. Again, it's tailored to the patient. And we may also need information from their real life. Sometimes when they're in your setting or in your session, they behave a little bit differently, and you don't really have a good feel for what the problem is in the daily living activities where they experience it. So we may need to do some kind of a remote assessment, either using telepractice or their smartphone recording or some methodology of acquiring information from that setting or that experience where the problem arises, so we can actually get a better feel for what is that. And that requires another kind of instrumental assessment, which is smart technology.
Don't get ahead of us. We're getting there. I did have a quick follow-up question. So really, this is a chance for clarification. So it sounds to me like a good scenario would be for a clinic to develop a protocol that is standard across the board that all patients that come in participate in. And in addition, if there are things that are interesting or perhaps clinically relevant, in addition to doing this protocol, you perhaps record someone doing something extra. So we're not sacrificing a protocol for including a dynamic evaluation. Would you agree with that statement?
Yeah. Oh, well, or you may have to modify it. If you have somebody who can't do everything on your standard protocol, of course, then you may have to do an adaptation.
And then also note that you need
and you note that. Exactly.
Yeah. Mm-hmm. Good practice, right?
Yeah. Yeah, I mean, you can't take the clinicianship out of it. We can't just be technical recipe generators.
Robots.
Right. And there's an art to solicitation of the tasks with your patients. So that in and of itself is dynamic.
That's right.
Within the protocol.
We wouldn't have a job, right? We could just give it to
I mean,
robots.
what's the point of the clinician if we could just have a computer generate the protocol, which can be done, but if you don't get what you wanted, who's there to judge it if it's just an automatic robotic recording? So you do need that judgment.
And then you miss out on my amazing personality.
Well, I would miss out on your personality if, yeah, honestly.
I have battled a little bit with this protocol. I think protocols are great. They can sometimes feel unimportant in that a lot of times you're getting general data when I have heard this person now for 15 minutes. I think I know what their problem is. I just want to record one thing. I think it's important that we put our own eagerness aside and continue to take these protocoled data. I would like to know if you have intel on the missing link. What is the instrumental missing link? From your research experience, is there some value or data set that we can collect that will give us more information and more quickly for a specific diagnosis or a family of diagnoses? Is it computer learning? Is it AI? Is it an acoustic value, an aerodynamic value, something else? Dark matter. Help us.
Well, when you put the question that way, I think the missing link in our assessments and instrumental access really has to do with insight on how a patient behaves in their real normal life. And there have been some researchers who recognize this and have developed tools for looking at daily life activities. The dosimeter out of the National Center for Voice and Speech. Bob Hillman at one time had a device, I forget what it was called because it was discontinued, but his lab is also working on a mobile device that I hope will be available in the near future. And it will be a disposable accelerometer that can connect to your smartphone and use an app to achieve the same goal in somebody's daily life. And I think that's a tool that could answer a lot of questions. The question remains, however, what is the optimal signal? So right now we're relying on accelerometry, and that gives us fundamental frequency, some sound pressure level.
Pause.
Yes.
Can you please explain to the novel listener just a brief explanation of what an accelerometer is?
So as the name sort of incorporates to accelerate, so it's a device that senses movements, and that device can sense the amplitude of the movement, the rate of the movement. That's it, in a bare bones way, that's what an accelerometer does. Yeah, so we have different places we can put it. So you can do an accelerometer in any body part, and it will tell you something about the rate of that movement, and sometimes, depending on what it senses in place, in space and time. It could also tell you amplitude. When we use it for voice, we've typically placed it over the thyroid cartilage of the larynx and use that to measure vibration source at the sound source of when voice is produced.
And so it sounds like the product coming out of Dr. Hillman's lab is potentially a disposable version of this kind of device.
Yes,
and
that would be great.
What is great about that?
Well, if it's disposable and it's something that we could use across multiple folks, I'm hoping that the actual part that plugs into the phone will be fairly affordable. And it would be something that, if deemed useful, the patient could then use it in their daily life for biofeedback purposes, for monitoring the success with which some of the benchmark outcomes that you set up for goals they're setting in therapy are achieved in their daily life. It gives you some documentation in hourly increments, perhaps times of day, days of week, that you get different patterns or associated with work, occupation issues versus social, soccer moms, hockey, whatever's going on in their daily life. You have a sample from their real life, as sampled in the same way across a lot of people. And the app itself can store that data remotely for you. It can also be uploaded somewhere centralized as a depository for your access. But it would give us a missing link that we lack in the very short-term period of assessment we have in our current assessment sessions.
We don't have anything natural, right?
No, we don't have anything natural.
Yeah, sitting in a room with my fantastic personality, while it's a lot of fun, is not people's normal.
Oh, I would perform so well for you.
You know,
I'd be on my best behavior.
Yeah, it's the therapeutic magic.
But to that point, how can we pocket this therapeutic magic and make it very tangible for our patients so that they do have this positive association with their voice, with their speech? And, you know, now that you mention it, why couldn't we pair this to something like dysphagia management, tracking the number of swallows or tracking how, you know, the larynx moves at the height of the swallow? These are all things that we can incorporate. And I think the emphasis of research recently has been, how can we capture this natural function for the purpose of training this natural function to be optimal? And it would be much to my chagrin if I did not give a shout out to Dr. Van Leer with all the work that she has done with these app-based therapeutic carryover techniques. And, you know, it's so exciting. I can nerd out about this functional therapy and assessment is phenomenal.
Yeah, generalization and carryover is what I think most voice clinicians don't spend very much time on, and is often, I think, the reason patients end up back in trouble.
The most important part, honestly, is generalization. Doesn't matter what they do in the clinic room.
No, that's right. That's why Jackie Gardner-Schmidt and Amanda Gillespie created the conversation training.
Right.
Holistic. I mean, you have to implement it right away into conversation, get trained up on that behavior modification, but generalization into real life. Lee Silberman voice treatment. You do daily phrases from day one. Lori Ramick came up with that generations ago. Well, I shouldn't say. Sorry, Lori. Decades ago. A couple decades, just yesterday.
We won't tell her. Oh my gosh. Well, and since we're on this topic, I would love to know even more about your thoughts on remote voice assessment. So at this time, how do you feel about them? Can we trust them? Tell us even more about what you know, your insider scoop on what's to come potentially with this. And can we use this data for research? What can we use this for at this moment?
Well, it's a great question, especially in the midst of a global pandemic and some significant barriers we faced during the past year when everything we do in voice is considered aerosolizing. So we've had to do a lot of adjustments. Our clinic, fortunately, was already set up pretty well for telepractice. And we serve a 5-state region, so many of our clinicians carry licensure in multiple states so that we can deliver care. what we were facing as a barrier was having them come in for assessment. So for a short time, we were completely shut down from the instrumental assessment. We had very isolated conditions under which we could do that. We had to resort to doing behavioral voice assessments using telepractice, clinical swallow evaluations, treatment. And one of the things clinicians were really missing, and also with my ASHA voice webinar had many questions on, was, can we get good recordings? One of the barriers with recordings is the variability in technological specification. So our audio signals, like what we're doing right now, it's great for communication purposes. Even on a telephone, we have a signal of our voice carried, but we're missing a lot of frequencies, or the compression of the signal alters the integrity of the signal for measurement. So acoustics in particular has a big barrier. Aerodynamics, of course, although you can come up with some non-instrumental ways of doing some inferences. There have been some researchers whose funded work was challenged, and they came up with some pretty clever ways to skirt around those issues, mostly having to do with shipping off instrumental equipment for the use of the patient in their homes. So the two key pieces are, you have to have a really good microphone that meets specification for carrying the range of frequencies your voice carries, and you need to have a software program that can record that voice in an accurate, reliable way. So PROT is useful. It's a free shareware. It's available. A researcher I know has relied on the software Audacity and allowed participants to download it on their computer, shipped off the microphone they needed to use for that recording, and did the instruction and the recording with the participant remotely, and then had an arrangement for the recording to be uploaded to a centralized depository. So we have some ways around it, but wouldn't it be cool if we could get to a point where manufacturers know what our specification needs are and build that into the technology we use in our smartphones, in our laptop computers? We could actually achieve, I think it's just a stone's throw away for manufacturers to do that without a huge cost to them. And we could then tap that for our audio recordings for remote acoustic recording. And then we'd have to come up with some, I bet you there are ways we could create some similar methods for aerodynamics. So I think there are some options there. So I also know the National Center for Voice and Speech is doing kind of an innovative bite block thing that they're developing that will also measure acoustics, pressure, and some resonating acoustic information, inferences of the formants and the spectral energies. So we have some really cool technology in the near future that may lend us a hand in having some ways we can do our services remotely. I also think it would be incredibly helpful if the CMS would approve nationwide licensure so we can not have to face this barrier where people who live in states or rural areas where they don't have access and they don't have anybody in their state that's licensed can get treatment from the places where expertise resides.
And that they don't waste their time and money on therapy that quote unquote might help when there are therapies that do help.
That's right. And just one example population right there, even though it's a rare disease, spasmodic dysphonia, now referred to as laryngeal dystonia, they'll average 4 to 5 clinicians of various backgrounds, 5 years before they get an accurate diagnosis to know what they have to get treatment. That's too long for somebody to wait to have access to the expertise. Certainly, if somebody has a voice problem, they'll be searching the internet. Dr. Google is a great source of information, but think about the resources that could be made available to people much better, much more efficiently. Again, another form of instrumentation or technology that could make all the difference.
Couldn't agree more.
How do you justify the time that it takes to do these studies, perhaps in a multidisciplinary clinic? And then how do you online perhaps interpret these data to both the patient who has just spent some time probably making some funny sounds in a microphone, as well as with the physicians with whom you work?
Well, I work with Marshall Smith, and he's been around a while and is pretty adept at knowing everything we do. So I don't have to justify to him at all. He's a wonderful partner. University of Utah takes great pride and has many awards now for several years running for patient-centered care and being one of the top places system-wide for that dedication. What that means is we have this value-added equation that we use. It's a cost-benefit analysis, but it's also outcomes-based and value-added based. So how I justify what we do is by estimating the added half an hour it takes us to do laryngeal function studies for, I think it's like $150 that we can charge for the added time that we're doing the analyses outside of the session we do our assessment. From that added time, we get information that we can document. Now the CMS, Medicare, requires us to do measurable outcomes. We can do that. We can actually quantify our outcomes. We don't just have to imagine it and perceive it and potentially be biased in our outcomes. We can quantify it and report it. Furthermore, because we do those added assessment pieces, we often more quickly identify something we might have missed so that we accurately have diagnostic precision more commonly than we do not, which means we efficiently recommend a treatment plan that's effective.
So in line with this, right, you brought up this example of people with laryngeal dystonia, what we know as spasmodic dysphonia, can often go years without having an appropriate and accurate diagnosis. Whereas if these same clinicians who maybe don't have the same exposure to this terrible disease process, if they were able to take something like an aerodynamic evaluation and you can see the breaks in airflow in connected speech, or see that there is a huge peak expiratory airflow moment after every voiceless sound, that is a huge clinical indicator. So that is a prime example of a way that you could justify. And selfishly, I also have phenomenal physician colleagues and in the institution that supports patient-centered care as well. And unfortunately, not everybody is in that same scenario. I think of people, my colleagues that are in a skilled nursing facility that pushes for productivity, for the community rehab center that is also very productivity based and perhaps not run by someone who knows about speech language pathology. So having access to these kinds of data points that demonstrate excellent care, excellent patient outcomes is something that you, the listener, should feel able to use for the purpose of justifying your excellent, this decade, evidence-based care.
Yeah, you can do measurable outcomes and report those. You keep your own database so that you can market yourself as, in this many patients, here's the degree of change we got.
Amazing.
And then I would also add for acoustics, we're showing that you can use it if you don't have access to imaging. One of the biggest differential diagnostic barriers we have that we're finding, the majority of our patients currently diagnosed with spasmodic dysphonia actually have essential tremor, a much more prominent disorder, more probable than spasmodic dysphonia.
Right.
Acoustics is better than your ear for measuring that. Furthermore, if you see the periodicity in the acoustic signal, you can also determine if it's laryngeal based or are other structures oscillating by whether you see format modulation versus only fundamental frequency sound pressure level modulation.
So can we give a physiological example? Perhaps the nasality? Would you like to talk about that?
Well, so if your tongue is oscillating, if you have a tremor in your tongue, a tremor in your soft palate, a tremor in your pharynx, you'll be seeing the formants 1 and 2 shift back and forth. They'll show, and well, what they'll look like on a PROT display is you'll see the same kind of tremor periodicity as you do on the fundamental frequency and sound pressure level. You'll see that periodicity. When you, if you do not have tremor affecting those structures that are not laryngeal, you will only see fundamental frequency sound pressure level if it's only in the larynx. So again, if you can't see it, you can at least acoustically record it and make some inferences based on the actual acoustic signal. it carries information about what the articulators are doing, as well as what the airstream is doing.
For you grad students who are perhaps in an acoustics class or a voice instrumentation class, that last 45 seconds is why you are doing what you're doing. Stop complaining, do the work, and learn.
You'll get through this.
Well, and if you talk to somebody who does neuromotor speech, they'll also say, and learn how to read a spectrogram, because speech can also be measured and you can get some real good measurable nuggets out of a spectrogram. So.
Thank you again for joining us, Dr. Barkmeier-Kraemer. It was a pleasure speaking with you, and thank you for all of your nuggets of wisdom.
Thank you so much for having me. This was really fun.
It was fun for us too. And to our listeners, thank you for listening, and catch you again next time.